Is it good to start now?
Yes, sir. You can start, sir.
Oh, okay. Thank you. So anyway, sorry. So at the outset, I thank Dr. Kavita and Dr. Vijay Bhaskar for giving me this great opportunity. I really appreciate that. They say learning is accumulating the information, then applying that information to turn it into knowledge, and then knowledge experienced becomes wisdom. Dr. Subbarao is a man of knowledge, but just not knowledge alone, extraordinary kindness, and whatever that I am today is mostly by watching him and taking inspiration from him. So it is really a great honor for me for asking me to speak, and thank you both, and also the KREST members. I really greatly appreciate this. Thank you. As far as the disclosures, there were few disclosures, but most important is that our pilot study on COVID neuroinflammation was just read as a paper in Australian Association of Neurology, where the neuroinflammation was the concept behind it. So the objectives of this talk are few and that order. I'll just briefly talk about pathophysiology, and then we'll discuss the drivers, the clinical drivers that drive this pathophysiology of neuroinflammation, and then what are the imaging strategies to identify this neuroinflammation, and if there is time, we'll talk about advances. As we know that the central nervous system is a highly privileged area, and the homeostasis is very tightly controlled. And this homeostasis is controlled by, at the level of the barrier, blood-brain barrier, and the cells that protect this are the astrocytes, we all know. The microglia, which are the resident phagocytes of the brain, take out the noxious substance and try to keep the central nervous system maintain its homeostasis. But there are triggers, like anywhere in the body, they're pathological triggers, and they would definitely disturb the homeostasis. Interestingly, in the central nervous system, there is also a physiological trigger. This physiological trigger, the interest in this physiological trigger is that it can induce the inflammation. The physiological trigger that can induce the inflammation is the apoptosis. So any kind of apoptosis, for example, aging, can cause neuroinflammation. So that directly translates our discussion into Alzheimer's disease. Response of the central nervous system for any one of these triggers is in the form of neuroinflammation. So that neuroinflammation, you have cellular and molecular mechanisms. They try to identify the event, limit its impact, and repair any consequent damage. So where does the radiology come? This is automatically jumping. I'm sorry, it's timed, so it's jumping. So the information, these three areas radiology can identify, and we will discuss that. As we just discussed, the microglia, which are the resident phagocytes, and the astrocytes are the two important cells, but their newer information tells us that the oligodendrocytes also are equally important. So there is inflammation, and this new inflammation causes neural injury, and this produces what appears to be a cascade. This cascade of extensive inflammation would, some irritant of inflammation will produce an unrelenting cascade of events where the primary event itself is not any more contributory, but the cascade itself causes much more damage. So there are two parts. One is a primary event, the secondary event, which is the cascade of unrelenting changes in the brain, which can cause the damage itself. So we have to be aware of that, and we have to identify that. Now, there are laboratory markers like albumin, neopterin, we can identify that. But what is the defining feature? The defining feature of any neuroinflammation is increased permeability of the blood-brain barrier. So the entire trajectory of all the radiology, of whatever the radiology is to identify where the blood-brain barrier abnormalities are and what are the consequences resulting of it. So extensive studies with ligands using PET and SPECT. Dr. Kavita is the authority on that, I'm nobody. But MRI can identify the footprints of this neuroinflammation very easily. So this is a cartoon which tries to tell you that these are the areas where there is abnormalities and different methods by which you can identify. They're too small to read, but the most important thing is that there is an noxious substance which has gone and attacked the blood-brain barrier. You can identify it with MRI with using lactates and myoinositols. Suppose there is a disruption in the blood-brain barrier, then you can identify it with using what is called a dynamic contrast enhanced T1 perfusion techniques, in other words. Then you can also see there is infiltration of the peripherally resident monocytes. They become macrophages, and then macrophages becomes the resident immune system of the central nervous system. So you can use various ligands to identify it, or you can use the super iron oxide particles to identify that. That's a very interesting area. Finally, consequence of neuroinflammation is the excitotoxic injury, which we'll talk about it a bit later. So just briefly about the blood-brain barrier. The blood-brain barrier is the contact point between the microvasculature and the neurons. And the vessels on the cells that line it are the brain microvascular endothelial cells, which we call them as BMECs. These BMECs are highly controlled by the astrocytes and pericytes and contribute to the integrity. And they have some transporter systems where they produce and they also absorb. So the efflux and the efflux systems are present on this BMECs. It's important because we need to understand the blood-brain barrier for neuroinflammation. But it is not only blood-brain barrier. The privileged brain also gets protection as well as a weakness with different barriers like blood CSF barrier. We know that the choroid plexus is also one of the agents where it can take or it can efflux. Then the circumventricular organs, they are present in every brain, and they also have a checkpoint to prevent things to enter into it. For example, a pineal gland, a pituitary gland, an infundibular stalk. We also know that the blood-nerve barrier can also contribute and prevent these checkpoints. But the most important I want to talk today is this lymphatic system. We know that central nervous system do not have the lymphatics, but we also know that there is a convection system in the central nervous system, which is responsible for taking out the noxious substance. How does it work? There are, for example, CSF is there in the ventricles, sulcal spaces, and cisterns. That CSF goes into the periarterial space, which we call it as VR space. Up to here, it's just a transudative experience. They just move by just convection. From the transudative convecting systems, this periarterial space CSF goes into the interstitial space and intracellular space. That's where the aquaporins come into picture. These aquaporins are extraordinarily polarized structures that present in the astrocytic foot end plates, and they try to push the water under some degree of dynamics. So that's important for us to understand because it's going to come in the play. So this lymphatic system is basically takes the CSF from the wherever it is, goes into the periarterial VR space, perivenous space, and then into the dural sinuses. That's how this lymphatic system works. Now, what are the imaging techniques? As we saw just about, okay, there was several imaging techniques that are present, which can identify all these things that we have talked about. That is blood-brain barrier disruption using dynamic contrast enhanced study, MR spectroscopy, water studies, magnetization transfer, so on. But the interesting part is the oxidative injury, KREST MRI. So I'll just jump few things and show you what is happening with the clinical entities. So we talked about triggers that cause neuroinflammation. Let us see what are those triggers and what are the things that we probably want to understand and see in a typical clinical scenarios. So multiple sclerosis, for example. Routine multiple sclerosis, perivenular and periventricular, and location. There is a lot of crosstalk. Can we mute that? Oh, okay. Okay. So the multiple sclerosis, you have all the characteristic observations. The most important thing is that there is myelin destruction. But it is also important to understand that both white matter and gray matter both are involved in multiple sclerosis. So let us see some of the examples of multiple sclerosis. When you see a multiple sclerosis, you have periventricular distribution. These multiple sclerotic plaques, when we see them, we think that it is active or inactive based on if there is perilesional edema or not. But interestingly, if you concentrate this particular T2 weighted imaging, there is also a thin rim of T2 dark signal. This T2 dark signal tells us that this is an active plaque. Not only edema, not only diffusion restriction, not only enhancement, but it is the T2 dark signal. That's what I want to identify that. The T2 dark signal occurs because the destroyed myelin, which has basically bilayer lipid, it has got macrophages in it. And these macrophages have T2 shortening effect because it's lipid. And that lipid produces that T2 dark signal. So it is not only the diffusion restriction, it's not only the edema, but look for T2 dark signal. That will give you tremendous idea whether a given plaque is an active plaque or an inactive plaque. That's one way of looking at it. The other common problem that we face in clinical practice, is it multiple sclerosis or is it microvascular disease? For that, you can actually use SWI imaging and demonstrate a SWI dark venule passing through it. So if you see the T2 dark signal on SWI and that plaque is around it, it's almost certain that it is a demyelinating plaque. So these are the small tricks that we do. Oftentimes, the clinician's question is it multiple sclerosis, which is much more fulminant in relapsing remitting or secondary progressive? Literature tells us that if the lesions are juxtacortical or intracortical, then the likely chance is that it is highly likely that it is secondary progressive multiple sclerosis. So you need to reconstruct the images in multiple planes when you see a plaque like this to say that it is juxtacortical or intracortical. For example, this plaque is filling the entire U fiber. So it is very difficult to say whether it is intracortical or not. But here is a plaque where the cortex is very clearly demonstrated and there is a plaque there, which is definitely intracortical. So demonstration of the intracortical nature of the plaque is extremely important for prognosticating the patient. And this is one of the important advantages of doing a volumetric flare imaging or volumetric double inversion recovery imaging. So in other words, you need to have thin slices volume acquisition to identify these intracortical lesions, which gives us an idea that this multiple sclerosis is unrelenting secondary progressive. So that kind of thing. So that's about the multiple sclerosis. Let us see the second thing that often as radiologists are asked. Here is a patient who has come to the hospital with a clinical diagnosis that there was a mass. Now, on T1 weighted imaging, you see this dark signal and a bright signal around it. People interpreted rightly as hemorrhage, and the diffusion was negative, but the periphery of the lesion did show some diffusion restriction. And the contrast enhancement was very patchy. Somebody interpreted it as some degree of PL inflammation. And there was relatively higher signal on T1 in the lower sections. Question is it a tumor? And the patient was to be taken to the surgery. So if I may ask or involve the audience and ask them, what would they say? I can't hear anybody. All right. Is there any input to me or no?
In the chat box, Ramakrishna says it is tumor factor demyelination.
Oh, that's wonderful.
Krishna.
Oh, I see. Okay. So there is an interesting concept of tumor factor demyelination. Why? Because it is size of the lesion does not seem to have the proportional mass effect. That's the most important point here. The most important point is the size of the lesion is not proportional to the amount of mass effect that it is creating. So we know demyelinations are not mass producing events, they are mass reducing events actually. The enhancement is incomplete, but that is a very, very superficial statement, and I don't like it because it depends on the ability of the MRI to identify all the complete layer of the demyelination, the volume entirely. So it may or may not show up. When you do volumetric imaging, it is more often than not, it is rounded. Third point is we have done the perfusion imaging. Perfusion imaging is the state of art. It's not anymore state of art. This is part of the routine MR studies. Any tumor will get perfusion imaging. And if there is a tumor, it would show increased blood volume. Now, we know that this is the lesion here. At the point where there is a maximum signal drop, you can actually see the venules going through it. So once we see that, there is no ambiguity that a tumor cannot have venules passing through it because it's a mass producing, whereas demyelination is perivenular. So look at the source data and demonstrate this at the point where there's a maximum signal drop. If you see these dark lines coursing through it, it's almost certain that we are dealing with a tumor factor demyelination, but not otherwise. Spectroscopy will help. DTI also will help, but they are advanced imaging techniques. In this case, where the DTI was abnormal here, has completely reconstituted itself. Now, this is the second patient whom I think I have sent it as a quiz, but I deliberately hid these two MRI data. So anybody who has kind of answered those quiz can come to and discuss this case. Here is a patient who has got the hippocampal abnormalities, and then there are parahippocampal abnormalities. They are not enhancing with the contrast. They are not mass producing, but they are bilateral. There is some degree of expansion. And on MR sagittal image, there is a focal lesion in the upper cervical cord, and there is a focal lesion in the mid cervical cord. So what anybody would think of?
There are so many answers in chat box, sir.
I can't see any chat box here. How do I see? Oh, I see. Oh, yeah. Sorry, my apologies. My apologies. My apologies. Autoimmune encephalitis, autoimmune, and no, very good. Dr. Sarath answers very beautifully that it could be NMOSD. So this neuromyelitis optica syndrome is a spectrum disorder, and it can typically involve the places where there is maximum aquaporins. We know these aquaporins are very high around the fourth ventricle, very high around the periaqueductal area, and you can see here the periaqueductal area is extremely bright and swollen, and it extends towards the medial hippocampal region. So this is not a typical MS. So there is a clear distinction, as Dr. Sharad said, that it is not a typical MS, and it has to be one has to be aware of it, and it involves areas which are not the so-called typical areas of the aquaporin disease also. For example, this is the MR of another companion case showing extensive white matter changes, almost like a deep white matter ischemia or an adult leukodystrophy, and there is this heterogeneous areas. And then whenever you have this kind, okay, this is another patient of aquaporin disease, and you have heterogeneous white matter changes. As I was talking to you about, the SWE is a gold standard in these situations. Look at SWE when you suspect it is a white matter disease or is it an ischemic disease. If the venule is crossing it, it cannot be a tumor, it cannot be a hypoxic insult, and so on. And it has to be a perivenular demyelinating changes. I talked to you about various types of blood-brain barrier checkpoints. And I also said that aquaporin water convection system pumps takes the noxious substance into the dural sinuses. So if you have a very active MS, you can try this in your place. I did not have a very beautiful case, so I picked up from the neuroimaging article 2017, where they demonstrated probably for the first time that there was actually a convection system showing the contrast leaking into the cortical sulcal space at a point of time, about 30 minutes, 40 minutes. People have demonstrated it at the end of 2 hours also. So basically you have to do a FLAIR imaging at a delayed time. Generally 45 minutes to 50 minutes is okay. In our case, we found it around 50 minutes. But it's interesting to show you the convection system where the contrast actually has gone towards this. This is a very, very important part because we agree now that it is the neuroinflammation that drives the MS. Another case, it need not always be this little dot. There can be a spread and fill function. And this is a case which is again from the Journal of Neuroimaging from 2017, where they showed this heterogeneous filling of the flare-associated contrast. Interesting observation. And we know that the PL lymphatics are the most important part now in MS pathogenesis. Okay, now let's see some parasitic and other causes which can cause infection and inflammation, and the different pathways that lead to neuroinflammation depending on the type of noxious agent. So it's interesting, and we'll see that. First of all, let's look at the autoimmune encephalitis. We know that there are 3 important clinical spectra in the autoimmune encephalitis. These 3 important are, we have seizures, we have cognitive problems, and we have psychiatric symptoms. But trust me, in my last 20 years, I have never seen one patient with this kind of classical symptomatology. It's one of the most challenging, extremely difficult diagnoses to make. I'll make my point about it. Just for the understanding of the pathology, this is antibody-mediated disease. It most of the times involves the limbic system, but any part of the brain can be involved. And there are 3 types. I just picked up each type one particular disease so that it's easy for us to go forwards instead of staying on one single topic. So there are antibodies. These antibodies against the intracellular antigens associated with malignancies. So intracellular antigens, remember that is the one which drives the type 1 type of limbic encephalitis or autoimmune encephalitis. This is, you can't treat it. You accept it and use basically a palliative methods to treat these patients. There is no definitive treatment. But the group 2 is a more amenable to treatment. There is a humoral immune response, a reversible, and it's a B cell activation. So these are here it is the cellular surface antigens where these antigens go and attack. Anti-NMDA receptor encephalitis is one best example. Group 3 is both B cell and T cell, and it is really I'm just bringing it's really a bad disease in glutamic acid decarboxylase. So I'll just show you some examples. This is a cartoon again. I got it from one of the websites, which nicely shows you what are all the diseases that occur at different levels. So let's see group 1, a small cell lung cancer, because that's the commonest for us. And this has involvement of the limbic system, majority of the times. So this is anti-WHO because the WHO has identified it. These are the cases from my hospital. So this is a patient who has come with very bizarre symptoms. No particular thing, but the personality change was there. So we identified this, that there is probably some swelling of the amygdala on the left side, right hippocampal volume loss. So I actually reported that there is a hippocampal volume loss. I don't know the cause. It is not fitting into the age group. And the fornix and the mammillary bodies do not show the Wallerian degeneration. I don't know what it is. So I did the perfusion, I did the MR spectroscopy, and I did APT, amide proton transfer, thinking that there was a tumor. It was not a tumor. Subsequently, after 3 months, the surgeon decided to biopsy this side. And you can see that little encephalomalacia in that post-surgical thing. And that revealed that it is actually a limbic encephalitis, anti-WHO. And the patient turned out to have a small cell cancer. The other case that we had, this was, the experience of this made us quite simple. This was, we know that this was limbic encephalitis because it's bilateral, symmetrical, hyperintense personality changes, not very difficult. The group 2, which can be more easily managed, need not always be in the limbic area. They can be anywhere in the cortex. They have diffusion restriction, and they have low blood flow by using the blood flow techniques of either you do a T2 perfusion technique or you do ASL, one of the two can give you this information that there is abnormality in the areas of different areas of the brain. The anti-glutamate acid decarboxylase, that's again very difficult. I don't think you can call it as such. You can say that there is limbic encephalitis, bilateral hippocampal involvement. There's nothing more that we can say. Question is, can it be a tumor? I'll just show you an example. Now, this is a patient which has come subsequent to the first patient. And then this side, he has only one side area of abnormality and some enhancement. I was very intelligent. I thought, oh, I made a diagnosis of unilateral limbic encephalitis. It turned out to be a GBM. I didn't do perfusion. I didn't do spectroscopy at the initial point of time. I called it as a limbic encephalitis. Patient presented with seizures, personality change, and I called it as limbic encephalitis. Turned out to be a tumor, and it's a GBM. So you can see the spectral markings subsequently done, which showed very high choline, suppressed NAA, not much of lactate, but it turned out to be GBM. Okay. Let's jump to the another interesting area, cerebral abscess. All of you must be seeing plenty of it. I'll just show you a few things that we are looking at. The classical finding in any cerebral abscess is the hypointense wall on T2. So first thing that I do is I look into T2. If I don't see a wall on T2, then I would not call that as an abscess. I would call something else. Then I look at SWE. If you have a dual rim sign, then I would definitely call it as an abscess. Diffusion restriction, when it is present, it is pretty good. And enhancement, generally books say it's smooth. I don't think I have ever encountered an abscess where there's a very, very smooth enhancement ever. But that's what the books say. I had one patient, unfortunately, I couldn't find it, but there was one patient where we do practically everything on any patient which comes. We do perfusion, spectroscopy, APT, and everything that we try to gather as much information as possible. So I did and they said, I knew that it was an abscess, but I thought I'll do a perfusion, and the perfusion showed high blood volume. So that kind of pushed me towards calling it as a metastasis, but I resisted my temptation and said, still called it abscess. Got operated, turned out to be a pyogenic abscess. So it is not always true that a tumefactive demyelination or an abscess can carry high blood volume. High meaning not high of 4.5 mils. A normal cortical blood volume of 1.5 to 2, it may be 2.5, but it can be there. So just be aware of it. Spectroscopy we routinely do to make a diagnosis positively before surgery, whether it's an aerobic, anaerobic, or fungal, or so on. We have a large population of patients who have got the HIV disease. So we try to look at toxoplasma as well. So here is a classical abscess looking at T2. It has got dark signal, it has got perilesional edema, and it has got mass effect. You may ask me, why not tumefactive demyelination? Well, it could be tumefactive demyelination if it has no mass effect. But once mass effect, it is something else. And once you have the diffusion restriction, our diagnosis becomes easier. Now, if I may ask, why would diffusion restriction happen in an abscess? If there are registrars. If there are no registrars, I will not ask all the consultants. They are more intelligent than me. I'm not asking them, please, excuse me. Are there any registrars? Dr. Kavita, can you hear me?
Yes, sir, I don't think so.
Ah, okay, sorry. Okay, so the abscesses have diffusion restriction, all of you know, they have low ADC, and the diffusion restriction is because the pus, and it doesn't allow the water protons to move, therefore there is restricted diffusion. And we always see the patients of abscess with this double SWI signal. So one, the peripheral part, and the second, the inner part. The inner part of high signal is the classical capsule of an abscess. So it is on phase data that you identify it and tell it. It's not the SWI positive peripheral coat, but it is the central or the inner layer, which is hyperintense. That gives us the answer that it is abscess. You may not have it in all the cases. We do definitely try to identify a given abscess as aerobic, anaerobic, fungal, because these are the hospital where I work, they have a very high-end cardiac transplantation, lung transplantation, total bone marrow, virtually all the transplantations are done there. So they would want to know this, and they have high confidence in our ability to identify it. So they just do ask it, and we do the spectroscopy. The spectroscopy is very simple, actually. We run the spectroscopy, we try to put the spectrum into the abscess and try to see what the spectrum tells us. So if the lactate peak is there only, and we don't see any other peak between the normal metabolites, we call it as aerobic, simple. Suppose this is an aerobic abscess, and this is an interesting case where there was an aerobic abscess, no other metabolites, and lactate alone. So, but they would not believe me. So the patient luckily had a liver abscess. So we took the liver abscess and did the spectroscopy, practically the same metabolites. So we know that, and it turned out to be a coagulase negative staph. So that kind of a thing. Whereas anaerobic abscesses, again, I could not find the right slide, but this is what you expect in an anaerobic abscess. If you have an anaerobic abscess, the pyruvate cycle metabolites all will start showing up. You have a acetate, you have succinate. These acetate and succinate, apart from lactate, you would see them. You know that where they are supposed to be present in a chemical shift. In this chemical shift of 0 to 4, if you measure it, the typical succinate peak is approximately at 2.7. So you look at 2.7, if there is a peak, you say that, well, this is succinate. I'm 100% certain that it's an anaerobic abscess. What happens with the fungal abscesses? This is the example of a fungal abscess. This is a cryptococcus. A lot of cryptococcus patients are there in the hospital where I work, and they don't much enhance, particularly when it's neoformous. And we want to look at these peaks. The peak assignment by the vendor MR spectroscopies are always a little faulty. We have different softwares, but I thought I'll just show you this. This is not really GLX and CR2. This is at 3.7 and 3.8. So trihalose. The trihalose is a lipid peak which is seen very classically in fungus. So that's what we see in this patient also. But here, look at it. This, although I just said that they don't enhance, this is a Cryptococcus gattii variant, so it enhanced, but still we called it as that, and we turned it with that. Then we always have the differential diagnosis between fungal, toxo, mets, and tumor. And how do we differentiate that? You always look for the diffusion restriction. If there is no restriction diffusion, then it could be a fungal abscess, it could be a metastasis. So you have to be careful. They take the clinical history. You cannot go by MR spectroscopy alone to identify that. Toxoplasma behaves like fungus, but the spectroscopy is different. They are rarely diffusion restrictive. Here is an example of a toxoplasma abscess, which is facilitative, but there is also another abscess of toxoplasma in the basal ganglia, which has got diffusion restriction. So heterogeneity is a feature, but generally speaking, toxoplasma do not produce pus. Therefore, diffusion restriction is not there. Now, this is a case which has come while I was in Hyderabad, and this patient had this large lesion. I want anybody to pitch in and say what you think. This is a young child, came with seizures and headache. That's all the history was. And this is the MRI where flared hyperintense, T2 heterogeneous, diffusion peripherally restrictive, and so what do you think, guys?
Fungal abscess.
Abscess. So that's the point is, it could be abscess, but it is slightly atypical for abscess because abscess would have central diffusion restriction. Here it's peripherally restricted.
Fungal abscess.
Fungal abscess, okay. But why would a fungal abscess have peripheral restriction? That was the consideration we had at that time. So we thought, well, it could be cerebritis. Let's do perfusion. And the perfusion was negative. You're absolutely right. It was an abscess. And the atypical feature in this patient is that it's peripherally restricted. So the point I'm trying to say is, if a well-formed abscess is there, there is no problem. It has got a central necrosis, peripheral capsule. But if you are trying to image the patient in between, at the point where the cerebritis is forming, you will not have the classical observations of abscess. You have a spectrum of peripheral restriction, central facilitation, and so on, until it gets very mature. So one has to be aware of that, and it turned out to be, again, an aerobic abscess. We have not talked about the opportunistic infections. These are JC virus infections often, but fungal abscess is also there. The JC virus, the importance of the JC virus is that we have to be very cognizant of the fact that JC virus affects the immunosuppressed patients. And these immunocompromised patients are either patients with MS who are taking natalizumab, for example, or HIV patients, and they are taking antiretrovirals. I'm sorry? There was somebody talking about it. Okay. So there were always a small chance that the given abnormality may be secondary to an immune reactivation. So PML and immune reactivation are extraordinarily difficult to differentiate. That's what I think. And contrast enhancement is the only way we can say, well, a given case is probably immune reactivation if there is a contrast enhancement. If it is PML, it generally don't enhance. That's the only thing that we can say. Typical PML distribution is subcortical white matter, not mass producing, do not enhance often, but they also enhance in sometimes. So now I have another 15 minutes. I think I'll complete it in a few more minutes, and then we'll talk about the quiz. Intracranial vessel walls can get inflamed in different situations. The thing about the intracranial vessel walls is that they don't have vasovasorum. They don't have if you see the extracranial carotids, they have a tunica externa and tunica media and tunica interna, but the external elastic lamina is absent in the intracranial vessels. There are several things that are little unusual for the intracranial vessel walls, and therefore enhancement in the intracranial vessels is consistent with inflammation. So here is a patient who had a normal posterior cerebral artery before contrast. Patient has been getting recurrent strokes. We gave contrast and there is intense enhancement. Similarly, normal left internal carotid artery in the paraclinoid segment that enhanced. The enhancement always is compared to the infundibular stalk. If the stalk enhancement is equal to this, then it's grade 2 or grade 3, depending on different people. But it is grade 0 if it doesn't enhance, grade 1 if it is less than stalk. So there is now enough literature available to tell us that if there is a vessel which is enhancing, that means that is an unstable block. The incidence of stroke in that territory is as high as 70%. So there is a big role that MRI plays. If you have a patient who is coming with recurrent strokes, please do vessel wall imaging. It's a standard imaging technique. There is nothing extra you need. You have a CSF suppression, you have a vessel flow suppression, and you have a PD sequence, and you give contrast pre and post and demonstrate that there is enhancement. Of course, you have to be cognizant that you have to reconstruct the vessel in multiple planes to identify sometimes, because it can be a time-consuming process for the radiologist, but it's an extremely rewarding area. So similarly, aneurysms. An enhancing aneurysm has got higher risk of rupture. That is well established now, very clear. We practically do for all the aneurysms. When you have plenty of aneurysms, say a patient has 2 or 3 aneurysms, which aneurysm ruptured? Previously, we used to learn that aneurysm larger, aneurysm which has nipples, aneurysms which are associated with vasospasm. All these are characteristics for the aneurysm which has bled. Not necessarily, please trust me, this is an aneurysm which is a branch of the pica, and that has enhanced. This patient also had earlier bled, and he had a much worse anterior communicating artery aneurysm. We treated this. Other areas which is quite interesting is vasculopathy. When you have vasculopathy and you want to identify it, just give contrast. You can see the vessel enhancement. Vessel enhancement is abnormal. Intracranial vessel enhancement is abnormal, regardless of it. This is a case where there is a lot of hemosiderin in the cortical sulci, and when you give contrast, they are enhancing. So you know pretty well this is amyloid angiitis. So that kind of a very short, definitive diagnosis you can offer with vessel wall imaging. So excitotoxic injury, I just briefly will tell you that it is something about the glutamates. So you use MR spectroscopy and identify it. It's a very involved area, but it's extremely rewarding area. Those who have got interest, please do send it to me some questions, and I will send you some of the papers we published. There is no problem. Other interesting developments are manganese associated enhanced MRI. This manganese is a calcium ion analog. So it goes and settles in the voltage through the voltage gated channels and identifies the areas which have got inflammation. And some of the exciting developments are with manganese. And there is finally SPIO, as I told you, is, the super iron oxide particles. They are pretty good actually. The macrophage which incorporates this peripherally injected. For example, if you have, say, blood transfusion, just go and get iron for the patients who are anemic, and just go and get the MRI done. You will see beautifully dark signal on T2 weighted imaging. And this is extremely useful for assessing the microglial activity in patients who have got neuroinflammation. What all they need is just iron transfusion and do the MRI. We do that. This is an example of MS where we have given iron transfusion and demonstrated more. I mean, this is a radiology article, but we do it all the time. And we demonstrate more plaques. Those patients who are going in for all the second and third generation natalizumab, all the maps, even if you give, some of them don't respond. You do this and demonstrate the activity, then they go for bone marrow transplantation. So they can be used for the aneurysms also, but nowadays nobody uses them. Finally, this is the most fascinating kit on the block, that's KREST MRI. This basically, it is an oxidative stress. We can identify these oxidative stress by doing MR spectroscopy with identifying the ascorbate and glutathione. This is glutathione ascorbate MR spectroscopy is a highly time-consuming process, so you don't use it. SWI you can use and measure the iron. That is another way of identifying the oxidative stress. But KREST is a very interesting technique where you measure the you give antioxidants. First you do the routine MRI and then antioxidants and then repeat the MRI and you do the subtraction. This is a very fascinating area, very, very rewarding area. And patients who have got unknown neuroinflammation, oxidative stress is very certain, and you can just give antioxidants before and after and do subtraction. Very interesting thing. So in conclusion, we have covered different parts of the neuroinflammation, the etiopathogenesis, and then, sorry, that was a recorded thing. This neuroinflammation, we have covered most of the areas that are associated with neuroinflammation. We looked at the multiparametric techniques, and we have also identified, we also looked at some of the newer developments in the neuroinflammation. This topic is only area that I did not cover was neuroinflammation associated with tumors, but I don't think there was enough time for it. Thank you.
Thank you very much, Joga sir. That was very inspiring and very educative presentation, sir. Really liked it. We all enjoyed, actually learned a lot from your presentation, sir.
Can you put that quiz from your end, or should I put it? I think it's easy for you to put it and ask.
Can you do it, sir? Can you do it from?
Yeah, sure.
It's okay, sir, because you can finish up the.
Again, we do not have to share our screen.
There is enhancing bilateral nasal cavities with bilateral turbinate hypertrophy.
I'm sorry, I can't understand you, what you're saying. Can you be clear?
Someone is reporting, sir. Someone is reporting and also listening to your lecture. That's what is happening, unfortunately.
I see. Okay. I'm sorry, I didn't understand that. Okay. I'm just trying to get the mail which I sent you, Vijay Bhaskar, where that.
Shall I put it up, sir, if you want?
No. I can just give me 2 seconds.
No, take your time. Take your time, sir. No issue, sir.
No, not this. Sorry. Sent items maybe. I think I will.
Vijay Bhaskar, you can put it up.
Yeah, thank you. I appreciate that. If you could just, one of you put it, because I don't know where I put it. Sorry about that.
You can stop sharing your screen, sir.
I can stop it. Yeah, sure. Basically, we addressed all the quiz questions, but I thought for completion's sake, should be there anyway. I'll just see it from my end also. Yeah, there it is. I found it, Vijay Bhaskar. If you want, I can just put it.
You can show, sir. Okay, I'll just.
Thank you. Okay. I'll just.
You can share your screen now, sir.
Yeah, sure. Can you see it now? Or?
No, you can start now. You start sharing, sir.
All right. Just give me a second. Okay, this is the case one where I gave the history that there was a female who was 30 years, and there was acute weakness in the left half of the body and transient loss of consciousness and seizures. We have T2, diffusion, and post-contrast. Chat box. I'm looking for the chat box now.
Can you read the answer on chat box, sir?
I'm just looking at, thank you. Acute demyelination, Jola Srikala, is that right? Jola Srikala, yes. Yeah, okay. She said acute demyelination. I think so. It is acute demyelination. I think I would have reported it as that. It turned out to be that actually. The interesting part is that the ADC is quite low, but again, look at this, there is no mass effect. In fact, I have another image of this where there was increased cerebral blood volume in this demyelination. That's what I wanted to show. But I didn't want to confuse you also. I did not send you that. There was increased blood volume, but we still called it as demyelination. The specialist was a bit upset with us for saying that it was demyelination. He is an MS subspecialized neurologist, but it turned out to be biopsy proven acute tumefactive demyelination. It's not MS, but acute tumefactive demyelination. Fantastic. It was not Ballous concentric sclerosis, but it didn't have the classical Ballous. As you can see here, there was few areas of enhancement. Okay, let's go to the second case where there was 35 with visual symptoms and seizures. And we discussed this case in the meeting, and we said that NMOSD. Somebody has said that it's NMOSD. Yeah. Dr. Sharath, yes. I don't know Dr. Sharath, but whoever you are, sir, you have made a fantastic diagnosis. It was hard. Then the third case, 30-year-old female, again, recurrent weakness and visual symptoms, no motor weakness, some asymmetrical visual defects. This is quite interesting. I deliberately did not show the spectrum disorder. I just let go. And that's what all the history we also got. This is the MRI. So we have flare on the top three planes, and then we have this SWI, post-contrast. Somebody says it's MOGAD. Can you elaborate it, sir? What is MOGAD? Dr. Sharath, can you elaborate what you mean by MOGAD? I don't know. MOG associated, okay. So myelin oligodendrocyte associated demyelinations are also white matter only. Very rarely they are cortical, subcortical areas. Here, what we see is mostly in the vascular territorial areas, and they do seem to enhance, but not much of anything. Yeah. Very interesting. Vasculitis or vasculopathy, that somebody said. Well, it could be vasculitis, but look at the mass effect. There is no significant mass effect on this patient. So that kind of worried us, and the diffusion was facilitative in this patient. And one important observation clinically, which I hid with you from you, and that was nasty of me, was that this patient has muscle weakness. Muscle weakness, very classical muscle weakness. And this patient also had similar episode about 1 year ago. That's right, it's absolutely right. So MELAS is a condition which has two important subclassical characteristics. One is it is not a excitotoxic injury oftentimes. As you have said, MELAS, that's phenomenal. I say, Dr. Sharath, superb. That is very characteristic, and it can produce increased permeability. Therefore, there is vasogenic edema. They don't enhance often, and the MELAS themselves, the lactic acid products, can go and block the capillaries, in which case they develop infarcts. So this is one such event where the MELAS has become a little more toxic and produced enhancement. Yeah, MELAS. Last, I think it's last, acute incoherence, seizures, fever 38.4, HIV, mild renal failure, CTA, reduced caliber of basilar artery, full vascular workup, normal. This is what we see. So we have a flare image, a diffusion ADC, and a CTA. This is important, you know. While I was studying, and I was even as a consultant, and while I was in India, we would not give you all the information, and we expect you to tell tremendous answers. Here, at the place where I practice and work, I'm also an examiner for the Royal College. It is mandatory that we have to give as much information as possible to the person who is taking the exams. So, and still it is one of the tough exams, I would say, but definitely it is much more fairer exam, I think. So this is what we saw, and the patient history I gave you. It is difficult, I think, but so the patient had renal failure on immunosuppressants. That's where the history lied, really, HIV. So we know that when you have a particular azathioprine as a drug, it can cause PRES and PRES-like malformations. When the PRES is extraordinarily, when the blood-brain barrier disruption increases, the PRES can be hemorrhagic too. So this is a case of classical PRES and turned out to be PRES. No, basilar artery is okay. It was vasospastic. As you know, the increased vascular permeability has got a spectrum disorder. I think a reversible cerebral vasospasm and PRES. They are on the extreme ends on both sides, and eclampsia is somewhere in the middle. All of them have one characteristic feature, that is increased capillary permeability. So this turned out to be PRES, and that enhanced after some time. So final case, seizures and dementia, immunocompromised again, male patient. That's what we see. Yeah, I think Ramon, sorry, I didn't see you, RCVS, you said yes, absolutely. Somebody said PML. That's absolutely right. Shabir Paul said it's PML. So that's absolutely right, but it's unusual because a PML enhancement is not really that common. But it turned out, in fact, it got published in one of the neurovirology journals. Neurovirology, not one of the neurovirology. It got published in neurovirology, where this is the first set of MRIs where we have flare, post-contrast T1 and diffusion. And the second set and the third set, each was done approximately 6 to 9 months gap. So here there was enhancement in the basic frontal parasagittal area. Here there was enhancement somewhere. I think there was no enhancement in the first scan, and the third scan showed enhancement somewhere else. So it was PML, and PML, though we study PML and everything, there is a new paper which we sent it to neurovirology, where we demonstrated that there was chiasmatic demyelination, nothing else, just chiasmatic demyelination. So the classical teaching may not fit into everything that we read. So to have that kind of a clinical picture, please do consider PML even when there is chiasmatic damage. That's pretty much it, I think. Thank you.
Thank you very much, sir. It was really a pleasure listening to you after so long, and we have that fond memories of learning from you in your presentations and all those salient features what you used to tell us. We still have the same reporting format what you use in LBIT. We use, most of us use it, same reporting format what you use, what you had used at that point of time in LBIT. So you are being followed so much, and among the KREST international webinars, you lead everyone by so many runs that it was almost touching a century. Never ever KREST webinars had so many audience. It tells us that sheer your skill, your caliber, and your teaching expertise, what is draws people to your lectures every time, sir. Really, thank you very much for what all you have done today, sir.
Thank you, Dr. Vijay. Really appreciate that. I greatly appreciated that you have given me this opportunity. I really appreciated it. Thank you.
We would love to listen to you in the next future also, sir.
Sure.
Yes, sir. I stress upon that. We would like to have your lectures. Of course, it's really difficult for you.
No, Dr. Kavita. Please let me